Host Lucy McBride here, primary care doctor in Washington, D.C. So happy to be here on my live, unscripted, fly by the seat of the pants podcast, Beyond the Prescription, where I bring you experts and commentary on things that are happening in your life, things that come to me all the time from my own patients. And so today I am thrilled to introduce you to a superstar. Amy Comander is a breast oncologist, so that means cancer specialist, at the Mass General Brigham Cancer Institute. She's the medical director of the Waltham Cancer Center and the director of lifestyle medicine of the lifestyle medicine program. Amy's a national leader in breast cancer survivorship and lifestyle medicine, and she is the co-founder of the Paving the Path to Wellness program. Her book, Paving Your Path Through Breast Cancer and Beyond, is amazing. And it's right here. And it's awesome. It's very actionable. It's evidence-based. And it's designed to help women thrive during and beyond breast cancer. So, Amy, thanks for joining me today. I'm thrilled you're here.
Thank you so much. I'm happy to be here too.
So today we're going to talk about breast cancer, prevention, detection, treatment, and survivorship. So let's start with like prevalence. Like talk to me about how common breast cancer is, and let's start there.
Right. So I'm so glad we're having the opportunity to discuss this. And so thank you for the invitation. So we know that after common skin cancers, breast cancer is the most commonly diagnosed cancer in women in the United States, but actually now worldwide. So in the United States, all women, we have a 1 in 8 lifetime risk for breast cancer. And as I tell my patients in clinic every single day when they're asking me, like, how did I get this? Which most of the time we do not know, I just have to say. But I say, being a woman and getting older, which is a gift, are our two greatest risk factors. And so breast cancer is very common. We all know someone with a diagnosis of breast cancer. But thankfully, due to incredible advances in early detection and treatment, we are curing more women. And then with breast cancer, people are living longer and thriving. And so really, I think it's a very exciting time in my field.
So I want to put a fine point on what you just said, which is that we often don't know why women get breast cancer and that the biggest risk factors are being a woman and age. So I think a lot of patients, particularly patients I've seen over the 20 plus years of primary care, think that breast cancer is a genetic phenomenon, that if you have a family history of breast cancer, that means you have a genetic predisposition. And I am quick to remind patients that genetics are important. Genes also are not destiny. But moreover, most people with breast cancer, most women with breast cancer don't have a genetic predisposition. They don't have a gene that they were born with that causes breast cancer later. Can you talk about the statistics there and talk about the like sporadic breast cancer, just bad luck, versus genetically informed breast cancer?
You raised such an important question because there is a lot of misinformation about this exact topic. So if we look at breast cancers in the United States and think of like a pie, okay, 5 to 10% of that pie are due to genes that we can test for in 2026. Think about many of your listeners have heard about BRCA1 and BRCA2, which of that 5 to 10%, half of the genetic cases would be due to those genes that we commonly test for. But increasingly, we've learned about other genes that can confer an increased risk of breast cancer, one called PALB2, CHEK2, ATM. There's a long, long list of them. They're much less common, but those would also be included in that. Again, only 5 to 10% of breast cancers in the US. And then there are sometimes families where there does seem to be a lot of breast cancer, but we really can't, as of now, identify the gene. Maybe it's a constellation of genes. Maybe it's single, these, SNPs that we can test for and find a like pattern that could explain the increased risk. So that is really the familial risk where we can't really find a single gene is about 10 to 15% of breast cancers in the United States. So that leaves a very significant part of that pie that we don't have a great explanation. So, certainly, as someone very interested in lifestyle factors, we do know that in particular for postmenopausal breast cancer risk, lifestyle does play a role, thinking about alcohol intake, sedentary behavior, postmenopausal weight gain, those all play a role, but they play just part of the risk. A lot of it we just don't understand. And that's what I explain to my patients. There should be never no shame, no blame, no guilt about getting a diagnosis of breast cancer because the majority of the risk we don't understand. Is it environmental influences? Just so many things we don't fully understand, which really is true for many diseases that we experience. So I think that's a good way to think about it.
Yeah, I think that's right. And I think the reason that is, I think, reassuring to patients that I talk to about breast cancer prevention and risk is because patients often come in and say, "My grandmother had breast cancer, so I think I'm at higher risk for breast cancer." And the truth is that, as you said, 90% of women who develop breast cancer don't have an inherited mutation that caused the cancer. Sometimes it just means you have women in your family. Given the prevalence of breast cancer, 1 in 8 women, as you said, will develop breast cancer in her lifetime. Um, Having breast cancer in your family just sometimes means you have women in your family.
Right.
That said, if you have a pattern like one of my patients who has the BRCA gene mutation where grandmother had breast cancer, mother had breast cancer, sister had breast cancer, that's a more obvious clue that you might need to be tested for a genetic mutation. And the reason to get tested for a genetic mutation is because if you were to have a mutation that increased your risk for breast cancer, that might actually change the way you screen for breast cancer. Um, so I just want people to understand that when you have breast cancer in your family, it doesn't mean you need to get genetically tested. It doesn't mean it means you it may mean you have women in your family, but of course talk to your doctor about, you know, the implications of genetic testing. The other thing I would say is that and I hope you agree with this, Amy, that like getting a negative genetic test doesn't mean you're not gonna get breast cancer. So the flip side is true too. Having a negative panel for breast cancer genetics doesn't mean you aren't at risk. Again, 90% of people who develop breast cancer don't have a genetic mutation.
Right. And I do thank you for explaining that so well. And I do want to say sometimes even, the patients I'm seeing in clinic, I'm a breast oncologist, so they have breast cancer, but there are many times where people are still unsure if they want to pursue genetic testing, even if they do have that strong family history, like the example you just shared. And my message is really knowledge is power. There are things we can do if we find out that, an individual has, for example, a BRCA1 mutation or if the family has it. And that test in one person would have implications for other family members in terms of thinking about what they should be doing for screening or consideration of, risk reducing surgeries to help prevent cancer in the first place. So I really think this area of genetics, and now we have, early detection for all kinds of cancer, that's an emerging field, is really interesting and powerful. Because again, I love that
Yeah.
concept, knowledge is power. What are steps we can take to optimize our health and reduce our risk of cancer in the first place?
I love it because, uh, there are other phenomena that we can genetically test you for, where we're more kind of cautious about the test itself. So take, for example, my patients who have a family history of Alzheimer's. My patients will ask me, "Should I get the genetic test for the ApoE4 mutation?" And the answer is going to be more complicated because you don't have actionable
Right.
tools to deploy when or if you got a genetic test that was positive for a mutation. So what's different about breast cancer, I think, is that there are things we can do. So there are things we can do. Like if you were found to be at higher risk, higher than the 1 in 8 risk, because of a mutation or because of some other reason, then it does change management. You can get more aggressive screenings. You could consider surgery. So maybe that's a good place to segue, Amy, into early detection for breast cancer and screenings. And I definitely want to make sure we talk about breast MRI because it's a question I get all the time. Um, let's start with the basics. Let's talk about mammography. Does mammography cause breast cancer?
Mammograms are our most important screening tool for breast cancer, and they do not cause breast cancer. And that is I will shout that from the rooftops, especially in October, which is Breast Cancer Awareness Month, but of course, every month of the year, because my goal as a breast oncologist, I would love it if there were no more breast cancers, right? So we want to pick them up early when they're small, easily treatable with surgery and less aggressive treatment. So yes, mammograms are our friend. We need to embrace them.
And then should women after age 40 typically get mammograms every year? This is a question I get all the time. I'd love your thoughts.
I
And
can
then when do
understand.
people stop getting mammograms every year?
I can understand. I mean, people are confused by this because sometimes the doctors are confused. There are so many different organizations. I see you nodding your head. There are so many different organizations, medical organizations that have their guidelines for mammographic screening. And some of them really disagree with each other. Okay. So it can be very confusing, not just for the patients, but for the doctors. So in general, I do recommend, for a person at average risk, and we can talk about what that means to start at age 40 with an annual mammogram. Okay. That is what we recommend here in the Boston area. And there are potentially rules for other screening modalities that we can discuss. And then you said, when should someone stop screening? And that's a great question because, in many of the trials that demonstrated the efficacy of mammographic screening for picking up early stage breast cancer, they stopped at age 74, right? So it's like I saw a patient this week who's in her 80s and she was asking me, should I still get my mammograms? And she does, by the way, have a history of breast cancer. So we did have a conversation about that. How does one decide to continue doing mammographic screening or not? And so we did have a very thoughtful conversation. And actually, in the end, she decided she was done. She did not want to have any more mammograms. And I supported her on that. So it is a really interesting question that you raised that I think often needs to be a shared decision between the doctor and the patient based on the patient's other medical issues.
So then let's talk about who is so if you're saying an average risk patient should get a mammogram starting at 40 annually, and then it's a shared decision with the provider or the doctor about when to end, um, or which could be at any age, really. I mean, some of my patients don't want to get mammograms ever. Um, so how do we decide who's at higher risk? You know, as we talked about, 90% of breast cancers happen not because of an inherited genetic mutation, but because of sporadic mutations in the cells of the breast for we don't know why. Because you're a woman, because you're older, because you've had more time on the planet for your breast cells to mutate and do funky things. So, how do we decide? Someone's asking a great question. Amber Hall, hey Amber, is asking about the Gale risk calculator. And I'd love to ask you about that, the Tyrer-Kruzik risk calculator. How do we decide who should get more aggressive screening beyond just a regular mammogram annually?
Great question, of course, and timely. So yes, there's a question about the Gale model, which any of us right now could Google that on the National Cancer Institute website, the Gale Breast Cancer Risk Assessment. Just a few questions. You could do it right now. It takes 2 minutes and see sort of what your 5-year risk and lifetime risk of breast cancer might be. That all of these are models. A model is what we put in, the input. And I'm thinking about your book. What is the input? What is the output? So it's not perfect, but it does give us, some information. There's also a model called the Tyrer-Kruzik, which you can also do yourself, which does have more questions. It's more nuanced. But I will say, so those are great tools. And I kind of think the Tyrer-Kruzik gives you a little bit more of a refined estimate for lifetime risk for breast
Can I interrupt you for 1 second?
cancer.
I want to spell it for people because I will
Oh,
say
please.
it. So it's TYRER hyphen
CUZICK. Yeah.
CUZICK. Yes. CUZICK.
So, so
Tyrer Cusick. And you can look that up online really easily and
yeah,
take the test to figure out what your Tyrer-Kruzik risk score is. And as Amy, as Dr. Commander just said, if your risk is higher than the average, projected risk, this is not
right.
destiny we're talking about. We're talking if your projected risk for breast cancer in your lifetime is higher than the average woman, then what?
So, right. So if it's higher than 20% based on that model, okay, then that would be an indication to talk to your doctor about augmented screening. What does augmented screening mean? Doing something in addition to the mammogram. So maybe a breast MRI 6 months after your mammogram. So alternating a mammogram with a breast MRI is one strategy we commonly would use. So some centers use a breast ultrasound. That's a whole other topic. There are now other tools on the horizon, contrast enhanced mammography, and also MRIs that have different capabilities. So this is an evolving field. Another important thing, which we should just address, is artificial intelligence. That is changing how we can do these risk assessments. And some centers are now, using some of these products, using artificial intelligence to analyze the mammogram images to predict a person's risk for cancer. So all of this is evolving. And I think over the next few years, even, we're going to have more tools, and it's going to make all of our jobs a little bit more interesting, but hopefully we'll be able to do a better job predicting who is at risk for breast cancer and what is the best screening tool for that person.
Let's talk about dense breast tissue. So dense breast tissue is a radiographic finding, meaning it's a way that the breast tissue appears to the reader of the mammogram, the radiologist. And dense breast tissue, as I explain this to patients, it looks like, so if breast tissue is sort of dark and black, and a calcification on a mammogram, a proxy for a tumor is white, and dense breast tissue is white. It means that the mammogram reader, the radiologist, is trying to find a white on white, which is hard. So it's like trying to find a snowman in a snowstorm. So that's my like sort of, primary care doctor's like distilled
Yeah,
version to tell
good.
people why, particularly if they have extremely dense breast tissue, meaning like your breasts look white on that image, then I really am recommending for most, if not all of those patients, that they get a mammogram annually and an MRI annually, staggered by 6 months. So they're getting an image of their breasts every 6 months, mammogram, MRI, mammogram. It's a lot of time with your breasts in a contraption. But
Yes.
I'd love you to hear your thoughts on that. And then what about people with like heterogeneously dense, like not that dense, but sort of dense?
Right.
The downsides of MRI, because it's not a zero risk procedure, can pick up false positives, et cetera.
Right. Very great points. So I looked this up with a patient the other day because on her mammogram report, it actually, which this only occurs in 10% of people, by the way, but it said extremely dense breast tissue. So that word extreme, I was like, oh, I don't see this all the time. And it is 10%. So that's why I don't see it all the time. So that individual should have an MRI, as you just stated, in addition to her mammogram each year. Heterogeneously dense breast tissue is very common. Actually, in women under 50, it could be up to like 40% of us. Okay. So, do all of those women need a breast MRI? I think that's more of a nuanced conversation, incorporating data, for example, from the Tyrer-Cuzick model that we talked about, or again, other models that we may use in the future. So I don't think every single person with heterogeneously dense breast tissue needs an MRI, but certainly it's a conversation based on her other risk factors. So
Not to
really great
mention that
point.
insurance isn't always paying for
Right,
breast MRI too, which is
right,
right. So I think that it's a conversation with your doctor. It's also, unfortunately, a conversation with your insurance sometimes as to whether or not someone with heterogeneously dense breasts or even extremely dense breasts will have their MRI covered.
right.
So
And I
any
also, you raised such a great question. Sorry to interrupt you about the
No, no,
false
no, 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 go,
positive.
please.
I actually talked to a patient the other day who was really debating, should she get the breast MRI? Should she not get the breast MRI? Because these are conversations. And I did explain, as you just said, like there is an increased risk of false positive rates, biopsies, like for individuals who get screening MRIs. If you've ever seen a breast MRI, thank goodness I'm not a breast radiologist. There's a lot going on there. Okay. So sometimes there are little things, and the radiologist is trying to be super thorough and recommending a biopsy. And obviously that causes major stress and anxiety. And I know my patients want to err on the side of being cautious, so we'll do the biopsy. But, I just want to say there is a high false positive rate, especially for the first one. So just being mindful of that. Any screening tests we do, obviously we have to weigh the risk and benefit. And that's true in breast cancer. And I'm sure so many other things that you see in your own clinic.
So let's pivot to prevention of breast cancer. What do you tell your patients who are recovered from breast cancer or are at risk, either high, medium, or low risk for the development of future breast cancers? What are the top kind of lifestyle or behavioral, you know, non-pharmacological ways that women can reduce their risk for breast cancer?
Well, I love this question. So I
This
will
is
say,
Amy's book.
thank you for sharing. And I have yours right here too. I just have some. See?
Yes.
Anyway, they're both awesome. So I will say that, increasing data is really demonstrating the important role of lifestyle factors as we think about cancer risk reduction. and, by the way, reduction of other chronic diseases. So, the most important one that comes to mind since I'm a runner is exercise. Okay. And some people are like, oh, exercise. Just the concept of using that term sometimes doesn't resonate. Thinking about moving your body, however that may be. Maybe, you're at work and you just get out for a 10-minute walk at lunchtime and do that perhaps a few times a day just to get outside. Really, our goal is 150 minutes of moderate aerobic activity each week. And you can do that however you want. So I think exercise is a really important strategy for all of us to think about, certainly for cancer risk reduction, but also for, again, other chronic diseases. And being at a healthy body weight, particularly after menopause. I know this is a challenging one. I talk about this all day with my patients too. So we recognize the challenges, and especially in the society we live in and all the environmental exposures, it's so complicated, right? But doing our best to avoid weight gain after menopause is an important thing to think about too. Limiting alcohol, following a plant forward diet. Note I say plant forward. So lots of fruits and veggies, eat the rainbow, whatever mantra you love. But really, that's so important. Limiting red meat, avoiding processed meat, also so important. So those are some of the key recommendations that I certainly talk about when we're thinking about cancer risk reduction.
I love it. I think the other thing is this is so helpful. So you're saying, Amy, just to recap, it's it's exercise that doesn't have to be fancy or formal or fanatical, the 3 Fs. It doesn't, right? Because you want to lower the bar. I mean, I'm the same way with myself. Like, if I tell myself I have to exercise like every day for 30 minutes, I just am not going to do it. But if I trick myself into exercising by like just walking the dog, I'm like, ooh, I did it.
Right.
It's limiting alcohol. It's thinking about metabolic health. So reducing your sugars and, processed food intakes. It's 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 reducing your risk for diabetes and other metabolic problems that and maintaining a healthy body weight when possible.
Yes.
Um, what about soy products? People ask me still about soy. I don't know why, but like 10 years ago it was a really hot question. But soy, like, is that a problem? And then of course um we have to talk about hormone replacement therapy and the risk. I mean, this is just the hot button topic. But talk to me about soy first.
Yes. So that is a major myth out there that, oh boy, if you eat soy, you're going to increase your risk of breast cancer. Or if you have breast cancer and eat soy, that's really bad. So I will say that is a myth. I did address that in my book as well. Soy is a great source of a plant-based protein, whether you like tofu or tempeh or edamame. And we know plant-based proteins are good for us. Okay. So I always refer people, there's a wonderful post and actually on the American Institute of Cancer Research website. There's a nutritionist I love. Her name is Karen Collins. She has a great article about this whole myth about soy, and she cites all the important references there. So I would encourage people to check that out, aicr.org, Karen Collins, and she just really explains it beautifully. But the research shows that soy consumption is safe, okay? That is really the bottom line. So don't be afraid of eating your tofu at the Chinese restaurant.
I love it. Let's talk about hormone replacement therapy. Hormone replacement therapy, or menopause hormone therapy, that is the taking estrogen and progesterone, the two hormones that your ovaries make until they don't at menopause. Taking these hormones, we have learned over time, is pretty much the standard of care after menopause, unless there's a reason not to be on HRT. In other words, when I'm talking to a perimenopausal or menopausal woman, out of the gate, the recommendation is to consider, not always do, but consider hormone replacement therapy for the short-term benefits on hot flashes, night sweats, vaginal dryness, sleep, all the things that are amuck around early menopause, and for the long-term benefits on bone health in particular, and we think on heart health and brain health.
Mhm.
So, and I do believe that women have been given, a lot of misinformation about hormone therapy. There's been a lot of fear-based messaging such that women for generations have been deprived of HRT unnecessarily. So one of the reasons, I'm preaching to the choir here, Amy, but I'm just talking to the audience here. One of the reasons women have been deprived HRT is because of the narrative that it causes breast cancer, and that if you take hormone therapy, you are going to get breast cancer. So break that down for me if you could.
Right. This is such a hot topic these days. So I'm glad that you raised this issue. So I personally was in residency when in 2002, when the Women's Health Initiative study was presented that suggested that there was an increased risk for breast cancer for individuals taking combined estrogen and progesterone replacement. And of course, that was like a big deal. And I was just in my residency. So I don't think I really fully appreciated the ramifications at that time when that was such a big deal. But we know now since that time, there's been a lot of fear about taking menopause hormonal therapy. And in general, when one really looks into the data now, which has been, scrutinized in great detail, thanks to so many amazing experts, the increase and risk of breast cancer is quite minimal from that study and actually not statistically significant. So, and the formulations they use in that study are different than what you use now in 2026. So in general, obviously with each person, you do need to take into account, of course, you know, their other medical history and potential concerns when deciding about MHT. But in general, the increased risk for breast cancer is quite minimal. And we know that for individuals who've had a hysterectomy, taking estrogen alone was associated with a reduced risk of breast cancer. So there's still so much here to learn, right? But in general, I don't think people should be fearful about taking MHT, if that's what you're asking.
Yeah, that's it. I mean, I think it's also hard, especially because the women who took estrogen alone in the Women's Health Initiative study, the largest ever randomized controlled trial comparing women postmenopausal who took HRT versus not, especially the women in that study who took estrogen alone, had a reduced risk for breast cancer. And that was not sung from the hilltops like the
Right.
other sort of more negative narratives about it were. So it's hard to prove, and I think impossible to prove causation between estrogen and breast cancer. So just because a study shows a link, a potential link, and in this case between estrogen and breast cancer, if it's causal, then it's producing risk, but we can't say that either. Doesn't mean that there's a causal relationship. So I get in trouble, and I think it's appropriate to suggest that it's not that I get in trouble. I would say it this way: the words we use matter so much in the way we convey risk, right? Risk is not monolithic. Risk is on a continuum.
Yes.
So when patients come to me and ask me, "Can I take HRT? Can I take MHT, menopause hormone therapy?" I really counsel them to reframe the question. Let's talk. It's not about can I or can't I. It's because it's not like one is a safe decision and the other is a not safe decision. It's really about what are the risks and benefits now and in the future of HRT for me, and what are the risks and benefits now and in the future for me of not taking hormone therapy, and then revisiting that conversation. Risk is on a continuum. These are
Absolutely.
not one and done conversations. And ultimately, the risk and what risk tolerance you have is up to you. But I think the point that's nice to hear from you is that you don't think a family history of breast cancer or necessarily it doesn't disqualify you from taking HRT.
Right. I think it's part of the conversation. And as we discussed earlier about screening modalities, if a person does have a strong family history, we want to make sure she's getting screened appropriately, mammogram, alternating with perhaps with a breast MRI, and certainly getting an exam. And if she opts to take MHT, menopause hormonal therapy, we know we're screening her very closely as well. So I don't think family history is an absolute contraindication. I will say another nuanced conversation, which obviously we don't need to get into today, but my patients who have had breast cancer who are now asking, can I go on MHT or menopause hormonal therapy? That is a much more nuanced conversation that, I think we as a field are grappling with right now. But, and I will say on a positive note, there is an amazing array of tools in our toolkit that we can now use to help those individuals manage side effects related to menopause that are non-hormonal approaches. So this is an area that we are all as a field learning more about how to help our patients best.
Yeah, I think that's so important. I think so many of my patients come in and say, "I have a family history of breast cancer. I'm worried about taking hormone therapy," or "I've had breast cancer, and I'm worried about taking HRT." Let's talk about can we break this down a little
Sure.
bit where we talk about breast cancers that are hormone sensitive. So, it is true that, whether or not estrogen and progesterone cause breast cancer, which I don't think they do, and I don't think we have any evidence to show that they are causal. Um, there are tumors, breast tumors that will have estrogen receptors, progesterone receptors on the surface of the cells. That is, they absorb estrogen and progesterone, which can water, so to speak, that tumor. So, for those people, it's important not to be on hormone therapy at that moment. In fact, we treat these patients, am I right, Amy,
Yeah.
with hormone blocking
Yeah.
medications.
Yeah.
So talk to me about a patient who's had like an estrogen receptor, progesterone receptor, positive breast cancer, and she's wants to think about hormone therapy post-treatment for breast cancer. What do you tell her?
Right. So it's super complicated, as you just
Yes, yes.
so I love that you just stated that breast cancer is not one disease. There are many different subtypes, and certainly hormonally sensitive cancers comprise about 80% of breast cancers in the United States. And when I say hormonally sensitive, as you just stated, sensitive to the female hormones estrogen and progesterone, those receptors are overexpressed on their tumors. And the most important medication we use to treat those breast cancers to help reduce risk of recurrence are medicines some of your listeners have heard of. Tamoxifen, which is a selective estrogen receptor modulator. What does that mean? It's blocking estrogen in the breast and it's acting like estrogen, for example, on the bones and uterus. So there's tamoxifen, and then there's aromatase inhibitors, which are lowering estrogen levels in postmenopausal women. So that class of medication is so important for our patients. And many of our patients are on these medications for many years after their surgery for their breast cancer. So when a patient is then coming to me, maybe she's finished her 5 years of tamoxifen or her 10 years of tamoxifen in some cases. Can I now go on MHT? You can see how these are very complicated conversations. And we as a field are really putting our heads together. I promise for all the breast cancer survivors and thrivers out there, we are grappling with this and trying to figure out, can we establish guidelines? How can we assess is this safe? We need research, okay? We need databases. We need to follow people prospectively. So this is complicated and it's very individualized with the patient. But I will say, of course, in my clinic, I will start with the non-hormonal approaches first. And don't think, oh, those don't really do anything. They do. We have amazing new drugs and treatments and lifestyle measures. Don't forget that. So we do take a comprehensive approach and of course listen to the patient. And we are trying as a field in oncology to do better to serve everyone.
Let's talk about vaginal estrogen.
Yes.
So vaginal estrogen, so Rachel Rubin is a very good friend of mine.
Oh,
Rachel's great, and I think a lot of the women HRT sort of menopausy. I mean, they're fantastic. I think they get accused of being over evangelistic about hormone therapy. And I think sometimes that's true. I think the messaging out there in the public square can be that HRT is for everybody and that it's gonna, do everything, solve every problem, it's gonna wash your car and do your laundry for you. But it's just a tool in the toolkit, right? So but that said, Rachel Rubin is the first to tell you, and I am as well, that vaginal estrogen is safe for everyone, even people who had breast cancer. It's not systemically absorbed. It is important for the genitourinary syndrome of menopause, the dryness, vaginal dryness, urinary frequency, pelvic floor dysfunction. So I commonly recommend vaginal estrogen for all women. I had a patient last week who's been on it for a year. She was getting frequent, she's 80. She was getting frequent UTIs, landing in the ER, getting resistant bacteria, and on vaginal estrogen, and she didn't know she had them. So on vaginal estrogen, she's much, much better. So anyway, let's talk about cancer.
oh, can I just wait one
Please,
comment?
please, please.
Thank you. I've learned so much from you, Dr. Rachel Rubin, and so many other wonderful people. I took Dr. Rachel Rubin's course, by the way, so I could learn everything about menopause hormonal therapy. Her course is amazing. Plus, I don't know if you know this, Lucy, I actually went to my first Menopause Society meeting last November. I took the exam because I want to be educated to best help my patients address these menopausal symptoms. So we as an oncology field need to be educated. And so
This
I'm
is
just
so
super
great.
interested. I'm taking a deep dive and I did prescribe vaginal estrogen many times this week in my own clinic. You'll be happy to know. I also prescribed flavanserin for the first time. So there you go. That's a medicine if
Oh,
you
awesome. I think it's pausing for a minute on that because I think, Amy, there's this bit of this artificial divide between academia and patients. There's this artificial divide between academia and you know medical messengers in the public square or in private practice, when in my opinion, and I believe this is you too, that we are all on the same team. Like
Oh,
whether you are at Harvard Medical School as you are, where I was back in the 2000s, or you're in private practice like me or on Instagram, like we are all a team. Like the goal
totally.
here is to help all women make sense of their bodies, understand their hormonal health, their options, and make smart decisions for them. And so I think it's awesome, a sign of great humility and strength to acknowledge what you and I were not taught in
Yeah.
medical school and in residency, like at Harvard Medical School in the 90s and 2000s. Like I wasn't taught about menopause. There's no, not, it was not mentioned. And so to go back and learn from each other, you from Rachel and from the Menopause Society, I think it's such a good, it's just so, I mean, it doesn't surprise me because I know you to be that person, but I think it's great.
I mean, I will tell you that menopause meeting was amazing. I learned so much that I'm using in my own clinic every single day with my patients. So thank you for saying that. We are all on the same team to help improve our patients' lives. So I'm with you 100%.
You can take vaginal estrogen, by the way, if you're taking an estrogen patch. In other words, like sometimes the estrogen
Mhm.
patch, which is systemic estrogen absorbed all over your body, doesn't reach the vagina, urethra. So you can take the estrogen patch and the vaginal estrogen together. Caveat always that you should talk to your own doctor. But, sometimes I'll do both because I don't want to up the estrogen systemic dose that'll give them sore breasts or vaginal bleeding. So we just do a little combination.
Yeah,
But as Rachel Rubin says, vaginal estrogen is like chapstick for your crotch. I mean,
it does
I
crack
don't
me
think too much of a prude to say that out loud, so I had to credit her.
up.
But anyway, that she's like just very, very matter of fact about it. It should be over the counter in her opinion. Um, so let's talk about in the last couple of minutes, like last 5 minutes, which is not giving it enough time. Amy, can you talk to me about like the current landscape of breast cancer treatment and
Ooh.
what it looks like? Um,
So I have to say, it is such an exciting time to be a breast oncologist. Okay, I mean, I just came back just a few weeks ago. We're in Chicago for the American Society of Clinical Oncology meeting, which, by the way, is the largest cancer meeting in the world. There's like 50,000 people there, maybe more. I don't even know. And it's for all types of cancer, of course. But of course, breast cancer, that's what I was focusing on. So there really have been so many incredible advances. We talked earlier, there are many different subtypes of breast cancer, just thinking about the concept of targeted therapies for different types of cancer, thinking about I'll just use one example of a study that was presented at ASCO for women with early stage breast cancer that's hormonally sensitive, that perhaps has gone to many lymph nodes. There was this genomic tool called, the test is called ProSigna, but basically another study demonstrating that using these genomic tools, maybe some of your listeners have heard of the Oncotype, MammaPrint. These are all tools that use a sample of the tumor to give us insight into the biology, the genes of that tumor that help us determine does a patient need chemo or not. Okay. So there was another study at ASCO looking at another genomic tool showing us that those who had a low risk result on that tool, even if they had many positive lymph nodes, could avoid chemo. Again, we don't want to overtreat people. We only want to give something like chemo to someone who needs it. So that concept of really tailoring treatment for the patient, so exciting. So I honestly, the field's changed so much even in the past 5 years, and I feel so grateful to do what I do and to see all these incredible advances.
you talk about breast cancer survivors and thrivers.
Yes.
Um, and I'd love to talk about cancer survivorship and what that looks like. I think in the US, people who get cancer often get tossed into this sort of bucket of like, you're a cancer patient and only a cancer patient. And as a primary care doctor, I'm clear to my patients that you are more than just a set of breasts. You are more than your cancer. You are more than we treat the whole person, and you're not defined by that tumor. And I sense that you feel the same way, and not to be Pollyanna-ish about it, but rather to be honest about the totality of the human being, mental health, physical health, social life, sexual health. Talk to me about what you like, sort of the themes of this book, which is
Yeah.
about breast cancer survivorship and, your path through cancer and beyond. Like, what would you say to a woman who's like currently in cancer treatment or newly out or even 20 years out, about what's your advice for that woman?
Right. So, first of all, I love what you just said. I think so many people feel defined by their cancer. Many women feel guilty somehow that they somehow caused their breast cancer. Not true. I saw a lovely woman yesterday, one of my new patients, who said, I hate my body right now. I'm mad at my body. My body gave me this cancer. So there are just so many complicated issues that our patients face, certainly with a breast cancer diagnosis or other diagnoses that we know people face. And I just really try to talk about, I love the work by psychologist Kristen Neff, which focuses on self-compassion, being kind to yourself, which is key, and talking to yourself like you would talk to a good friend. Would you tell a good friend, you did cause that breast cancer? No, you would never say that to a friend. You would talk to that person with kindness and compassion and empathy. And how can I help you move forward? What are the steps we can take to help you go through treatment and to truly thrive and live your best life after this diagnosis of breast cancer? And that is exactly what inspired this book. And by the way, I don't get the credit for this. My patients inspired this book. In this book, for each topic we cover, there are beautiful testimonials. We call them live and learns from patients. Most of them are my patients who participate in the program, who reflect on their diagnosis and how their lives have changed and perhaps how they've embraced managing their stress or focusing on the key role of social connections, things like that, how their purpose has changed after their cancer diagnosis. Those are the stars of this book, okay? And it just makes me tear up to read their reflections, even now, even though I've read this so many times. So, really, I think people need to learn about, certainly do everything you can, as outlined in your beautiful book, too, to advocate for yourself and get the right treatment for yourself, but also think about what are the tools you need to truly thrive after a diagnosis of breast cancer.
I love the way you frame it, Amy. You're clearly an empathetic, compassionate doctor, and in addition to having, you know, amazing tools at your fingertips for cancer treatment. And I think our jobs as physicians, and I think this is not just in oncology, but in primary care and in all fields, is to center the patient, not just their disease. And I think what's important about that in my mind is that patients have more agency than they often think. I think people think of cancer as something that they either caused themselves or that was written in the stars, and they sometimes think they don't have as much agency or control over outcomes that and when they actually do. So, my book is about understanding where you have to accept certain issues. Like, you may have to accept that. Thank you, Amy. Promo time, promo time. You may have to accept that you have a genetic predisposition to breast cancer. You may be one of the 10% of women who has that inherited genetic mutation. What you can do, though, is get more aggressive screenings, consider mastectomy, consider non-surgical options, and work on the lifestyle factors you talked about: limiting alcohol, getting exercise, working on metabolic health and weight, and, thinking about your whole health. So I think the goal here in my mind is to empower people with information and to know where they have control, because oftentimes we have a lot more than we think.
I love that. Absolutely. Such a great, great message.
Well, that's the message of your book. I mean, we're like, your book, your book, your book. No, you, no, you, no, you. But I
Yeah.
but I do encourage you guys to read Amy's book. If you have someone in your family who you love, or maybe it's you yourself who has been through breast cancer, or even who's at higher risk, like, reading this book, I think, will provide reassurance, and it will provide you a roadmap and practical tools. Um, and Amy, on the last note, I would just say thank you so much for joining me. I've learned so much, and I really enjoy the conversation. I love when academics meet private practitioners and we talk about these things together, because we're all, at the end of the day, on the same team.
Yes. Thank you so much. And thank you for everything you do to educate all of us. Really appreciative.
Bye, Amy. I'll send this out next week, and have a great weekend.
You too. Thank
Bye,
you.
everyone. Thanks for joining.
Thank you.